Good evening, colleagues, and welcome once more to our weekly clinics webinars that we host on a Thursday evening. And this is one of those evenings again, once more, when we come together and share knowledge on medical education and medical practice and clinical experience. And we're excited again once more to meet with you. We had a break last week when we were celebrating Youth Day and we couldn't join you, but I'm glad that I can still see that quite a number of you have logged in once more to this webinar. You'll excuse me if there's going to be load shedding, if I lose pictures, it's because of load shedding. Please note that these webinars are CPD accredited, and we request that when you join in, you make sure that you provide us with your full details so that we can then upload your information to the relevant parties like the HPCSA, the Nursing Council, the Pharmacy Council, or the Allied Health Professions Council, for those who are registered with the council. And so this evening, these webinars also know that they are streamed live on YouTube. So this evening or even tomorrow, you'll be able to get a copy of the live streaming. And so we are glad that we can join with you this evening. And so tonight we having one of our own specialists, Dr. Jaffer, who's a specialist surgeon in private practice. She provides holistic surgical management for patients from a pre-operative workup and counseling to post-operative wound care and recovery. And communication and understanding are very key to her everyday management of all patients. Dr. Jaffer completed undergraduate studies at the University of the Witwatersrand, obtaining an MSHB degree in 2013. She then completed an internship and community service at Kwezanibara, one of academic hospital in Soweto, just opposite one of our hospitals, Dr. S.K. Matsik Memorial Hospital. And Dr. Jaffer further pursued general surgery training at the University of Pretoria, where she became a surgical registrar in 2017 and attained a college examination in surgery and Master of Medicine in Surgery in 2021. During her time in registrarship, she presented multiple research papers at surgical congresses. The research topics presented at that time included monocytic profiles in breast cancer patients with and without HIV infection, audit of adult burn patients presenting to Calafong Provincial Tertiary Hospital, and ileosigmoid node, the Calafong Hospital experience. Our colleague, Dr. Jaffer, as mentioned, has got an MSHB and also a diploma in nutrition and also a diploma in nutrition production. Also, she's a specialist surgeon and working at Tepa Temba Private Hospital in Dobsonville currently. And tonight she's going to be talking to us about on the overview of medical and surgical weight loss. And we are excited to have you in our midst, Dr. Jaffer. And I trust that your family is also in the webinar this evening. They support you quite well. Thanks for that, Tanwir.
Oh, can you guys hear me?
Yeah, we can hear you very well, quite clear.
Okay, awesome. So thank you so much to Clinics for having this webinar and inviting me. Really means a lot. Can y'all see my presentation?
Yes, Doc, we can see it.
Okay, all right. So Dr. Billa, thank you so much. So tonight I want to take you guys through an overview of medical and surgical weight loss. This is by no means an in-depth discussion of everything that we can do regarding the medical and surgical things. However, I just wanted to give you all an overview and maybe we can have a nice discussion at the end. So as said previously, my name is Tanwir Jaffer, and specialist surgeon and weight loss endoscopist. So let's see if my presentation works. Okay, technical issues. Okay, so just I do apologize. Please bear with me. This thing did not load as we would have wanted it. but we will make do with what we have.
Kamul assist you to load. It was there. It disappeared just now.
Okay, there we go. I think I'm back. Just let me know if I mess it up again. Okay, so today what I want to cover is just the obesity classification systems, the pandemic of obesity in South Africa. We'll look at some weight loss modalities. We'll look at the new thing on the market, the GLP-1 agonist, which is your Ozempic and your Saxendas. We'll look at the endoscopic procedures that we can do regarding weight loss, which is your intragastric balloon, as well as your endoscopic sleeve gastrectomy that we can do. And then just to cover it off, we'll do a surgical weight loss options, just so that we've got a holistic overview of what we can do. As I've said previously, this is only an overview and in no way an in-depth talk of medical or surgical weight loss options. Right now, whenever we're looking at anything in medicine, we need to all be speaking the same language. And we need to classify obesity so that everyone is on the same page. Right now, an ideal obesity classification method needs to be practical. It can't be some things, and you'll see in the presentation as we go along, things that are mentioned in literature, but they are just there. They're just for the literature. They are more for research purposes, and they are not in any way practical and widely available to practitioners. It needs to predict a health risk. It's pointless having a classification method that is just there for research. We need to somehow use that to predict the health risk of the patient. And when the patient is sitting in front of us and saying, listen, doc, I've got X, Y, Z, what can I do about it? We need to be able to use that classification method in order to assign some treatment strategies and goals so that we can help these patients and give them a plan. Because patients like to come in, tell them what's the problem, and then we need to leave with a plan so that we can sort out that problem. Right, now, there's different things that we can use to measure body fat, right? And some of them, as I said, it's more for research purposes and it's completely impractical to use in everyday use. So underwater weighing, I'll show you a picture and we'll go through it a little bit. We can use a DEXA scan as well, CT scan as well, and an MRI. Right, now a DEXA scan, this is basically what they do to the patient. So this is the DEXA, but let's look at the underwater weighing. They put the patient on this little swing, submerge them in water, and what you want to look at is the amount of water that is displaced. If a person has got more lean mass, more muscle mass, more bone mass, there will be more water that is displaced. Regarding the DEXA scan, this we can look at, actually, we can look at our symmetry of it. We can look at the fat, which is the yellow bits here. We can look at the muscle, and we can look at the bone mineral content. So these are all nice to have and nice to mention in your literature, however, very impractical. So what a lot of us use and what your medical aids will normally use is a body mass index, your BMI, but that does not give us a full view of the risk that the patient has. So we need a waist circumference. And what the waist circumference does is tells us about central obesity, because central obesity is really the key factor when it comes to determining your metabolic health and your metabolic risk. All right, so let's go into this. I know it seems a bit mundane, but let's just go into it so that we're all on the same page, right? So now your body mass index, we all know, is weight in kilograms over your height in meters squared. And your BMI correlates quite well with your body fat percentage. However, with anything, we need to look at our different populations. So it's unable to differentiate between your lean mass and your fat mass because we're only looking at the kilograms. So in our big young males that come to us, normally they are bodybuilding, they're going to have a higher BMI because they've got more lean mass, more muscle mass. The older patient, as you get older, you're going to be losing your muscle mass. So your older patients normally has got a lower BMI, but they do not have muscle mass. They have got more fat, right? And it does not, as we said earlier, it does not identify the fat distribution, which we talked about, central obesity. Now, with that central obesity, if we look at the different races, the genders, the ethnicity, and the age groups, men have got a lower body fat percentage because they've got higher lean mass. They're more muscular, they've got a better, a higher bone density. Okay, so that has to be also kept in mind when you're looking at the BMI between your males and your females. Our Asian population, our Indians, higher body fat percentage at a lower BMI. And these patients normally have got quite a bit of central adiposity. And then, as we mentioned earlier, lean mass is lost with age. So whenever we're looking at a BMI, good to do it, but always keep in mind these different things that can occur. All right. Now, central obesity, as we said, it's the typical presentation of a patient with very skinny arms and legs, then a very big abdomen and trunk. And this has an increased risk of your metabolic syndrome, which is your type 2 diabetes, hypertension, as well as your increased cholesterol, as well as heart disease. Now, in many books and in many literature and guidelines, you're going to see that they're always going to say, compare the waist to the hip ratio. You know, it's going to depend at where you think the fat person's waist is compared to their hip. So a single circumferential measurement at the level of the superior iliac crest is quite a good measurement. And you have to measure it in the same way at each visit so that you've got a good track record of what the patient was, where they are now. Okay, now let's spend a little time on this BMI table. We've seen it, different literatures will have different figures, but it's generally around the same figures. So anything less than 18.5 is considered underweight. Your normal is 18 to about 25, right? And when we're looking at waist circumference, your females, they're healthy if they've got less than 88 centimeters. Your males, less than 102 centimeters. Then we come into this overweight class, and that's where things get a bit spicy, right? So overweight, you're looking at 25 to 29.9, they are overweight. And within that, you're going to have different classes of obesity. So class 1 obesity, we're looking between 30 and 35, that's obese. Class 2 obesity, 35 to 40. We also classify that as severe obesity. Class 3 obesity, 40 to 49.9. Right, morbid obesity, and anyone over 50 BMI, they are called the super obese. Okay, but I suppose once you come over 40, I mean, we need to do something, even maybe at a lower BMI, about 30. Now, body fat percentage can be directly measured using your DEXA scan, your CT, and your MRI. Directly measured in the sense that you've got imaging, and then you can go and measure how much fat is at different points for all the DEXA, the CTM, and the MRI. Indirectly measured was the water, which we went through the underwater weighing method. This air displacement bod pod, I haven't seen it physically in person. I'm so sure some fancy gym out there has got a bod pod. And the idea behind it is that the patient sits into this thing, gets closed, and then they have some sort of waves that goes from the inside, from the anterior to the posterior aspect of the patient, and then they see how much air displacement occurred. Your bioelectrical impedance analysis is also indirectly measures your body fat percentage as well as your muscle mass. But just keep in mind that these can be affected by conditions that alter your fluid status of the patient. So if the patient has got a congestive heart disease, liver disease, or chronic kidney disease, they're going to be having more fluid, which can alter all of these measurements. Now let's look at obesity in South Africa. We know it's a problem. We've all seen them in our practices. Now in South Africa, half of all adults are overweight or obese. The World Obesity Federation anticipates an additional 10% increase in obesity amongst adults by 2030, which is right around the corner. And in 2021, they estimated 11% of people older than 15 already had diabetes. Now, we know that diabetes increased weight and obesity increases the risk of non-communicable diseases. Your diabetes, hypertension, cardiovascular diseases, arthritis, certain cancers. And if you look in the literature, there's quite a bit of cancers that have been linked with increased weight, all the way from your stomach cancers, the gallbladder cancers, colon cancers, breast cancers. So there's quite a lot of cancers that are affected by this. And these non-communicable diseases does cause life-altering illnesses, disabilities, and premature death. Now, I found this in one of the articles as we were going along, the references on the top there. And you can see quite nicely that in 2010, we had about 5 million people or 7 million people that were obese and overweight. And that had spiked up quite drastically going 2025, 2030 projections. So this is something that we really need to look at, and something that can really cut costs if we can decrease the obesity related diseases. Now, this was in 2020, where they looked at the obesity related diseases and the costs related to it. So 19.86 billion rand was spent for your diabetes and the diabetic complications, 8.8 billion for the cardiovascular diseases, 3 billion for the musculoskeletal, 395 million for the digestive diseases, and that was more your gallstones, your cholecystectomies, things like that. 360 million for the respiratory diseases, and that really did come about more with the COVID, and 352 million for cancers. So quite a lot of money goes into obesity and obesity-related complications. Now let's look at the weight loss modalities. And there is all the way from diet all the way down to surgery. Now, I'm not going to cover the diet. We all know that low-calorie diets do increase the chances of you losing weight. This is not going to be covered. Physical activity is not going to be covered in this talk. Lipolytic agents are not going to be covered. I am going to go across some of the medical weight loss options, some of the endoscopic weight loss options, and some of the surgical weight loss options, not taking anything away from the others. I just don't think we have enough time to cover each and every one of them. Right, so now let's look at the GLP-1 agonist. All right, so these are your glucagon-like peptide-1 agonists, also known as your incretin mimetics. It was initially developed to treat type 2 diabetes. Ozempic is being used off-label for obesity. However, I did see in the US, I stand to be corrected if it has already been passed in South Africa, where Wegovy has been for obesity. All right, so semaglutide is your Ozempic, liraglutide is your Saxenda, and those are the two that are very common in South Africa. Okay, now how does it work? What is the mechanism of action? And I want to go to the other slide, which actually shows it quite nicely, where your GLP-1 agonist is meant to increase or improve your plasma glucose. It also decreases your blood pressure and decreases your plasma lipids. So it works on almost every part of the human body. It decreases the appetite, increases the satiety, so they feel fuller for longer, and that's sort of more of a restrictive part of the diet. Increases your insulin, decreases your glucagon, it decreases your liver fat, decreases insulin resistance. It also improves your cardiovascular system by improving your endothelial function, decreasing your arterial stiffness, therefore decreasing your blood pressure. And it also increases your myocardial contractility, decreasing your glucose uptake in the heart, and actually giving better outcomes in your cardiovascular patients. So this GLP-1 agonist was initially used as an adjunct to your type 2 diabetic treatment. So the first line treatment for type 2 still remains metformin. It is not the Ozempic, it is not the Saxenda, it's none of that. The GLP-1 agonist is considered if patients have got intolerance or any contraindications to metformin. Now, what are the contraindications to metformin? Renal dysfunction, congestive cardiac failure, hypersensitivity to metformin with the lactic acidosis, acute or chronic metabolic acidosis, impaired hepatic function. Now, intolerance to metformin These are the patients who's going to come in who, since they've been taking metformin, have been vomiting every day, has had intolerable diarrhea, and these patients are not going to have good patient adherence to metformin if they've got those side effects. So in those patients, if you want to use Ozempic, if you want to use Saxenda, that's a good patient to be considering it in. If the HbA1c is more than 1.5% over target, I think in the ideal world, this would be great. Ozempic and Saxenda are quite expensive. And I think in our general population, a lot of people are not going to be too excited over the fact that if the HbA1c is more than 1.5% over target, that they're going to be put on another medication that works, but is quite expensive. And the other indication is if they do not reach the HbA1c target in 3 months, especially if they've got other risk factors such as heart failure, chronic kidney disease, or atherosclerosis. Now, I just looked at the two, I didn't include the others. So your Ozempic and your Saxenda look very similar to your insulin pens. Okay, so your semaglutide is injected once weekly and it's going to go up every month. So from 0.25 milligram per week, the next month you're going to increase it to 0.5, then 0.75, then 1 milligram. So you're going to go over 4 months. It's approved for type 2 diabetics. The Wegovy is going to be approved for the weight loss patients. But as far as I'm aware, it is still not approved for in South Africa for weight loss. So it is being used off-label for the weight loss. The Saxenda is the liraglutide. It's injected daily. So that's a big thing in terms of patient adherence. If you've got a patient who is already on insulin, they are more welcoming to the fact that they've got to inject another one because they're already injecting themselves daily. However, if you've got a patient who is only on metformin and now you're telling them, listen, you've now got to now inject this daily, you might get a bit of resistance depending on the outlook of that patient, right? The Saxenda is approved as a weight loss medication. This one here, you're going to start at 0.6 milligrams per week. Remember, injecting daily and then increasing it every week by double. So from 0.6, 1.2, 1.8 up until you get to 3 milligrams per day. The side effects, very big one. There's a risk of a thyroid CA, and this has not been proven in the human population because we have not been using it that long. However, in the animal studies that they did, I think it was the rat population that almost all of them got a medullary thyroid carcinoma. So just a warning, if the patient does have some sort of a MEN syndrome, just to maybe not give them Ozempic or Saxenda. And then you've got your normal side effects, your nausea, vomiting, diarrhea, abdominal pain, and constipation. And this normally improves as the patients use it and as their body becomes more accustomed to it. Pancreatitis and gallbladder diseases have also been cautioned about, and this is just for you to keep an eye on should anything occur. Okay, now let's look at the endoscopic balloons or endoscopic procedures. Now, back then in 1939, Michael DeBakey, and he was the same guy who developed the vascular forceps. So Michael DeBakey in 1939 noticed that 30% of patients experienced weight loss who had gastric bezoars. Okay, so for some reason, he decided that in all of his gastric bezoar patients, he's going to see how many of them experienced weight loss and what was their symptoms. And he had actually noted that down, that most patients with a gastric bezoar actually experience weight loss. So there was a husband and wife couple in 1985 that made the cylindrical central hollow channel look more like a tin can. And they inserted it into patients. They left it for 4 months and they had just filled it up with 200 mils of room air. And they had run this experiment to see if they could sort of induce weight loss in patients like that. They had a good idea. I think back then the actual make of it was not maybe the best, but we learned from it. The complications that they had from the central tin can looking thing was that it caused a lot of ulcers. It induced a lot of vomiting, and that gave them Mallory Weiss tears. Sometimes it went through the pylorus, gave small bowel obstructions, and then because of the shape of it, caused a lot of gastric erosions. But that was the start of endoscopic weight loss procedures. Now, your ideal balloon characteristics. need to have a high, it needs to have proven that it can cause weight loss. It needs to have radiopaque markers so that from a normal X-ray, we can see where the balloon is, right? It needs to be adjustable, right? So adjustable, and I'll go through it, there's two different types of balloons. One is an adjustable balloon and one is a non-adjustable balloon. Your adjustable balloon is like a SPETS 3 balloon. I'll show you a picture later. And your non-adjustable is your Obera balloons. So the nice thing about the adjustable one is that when patients plateau, you can always go back and use the same balloon and just increase the amount of volume that they've got in it. So it's not a one and done procedure. So the adjustable one is much better than the non-adjustable one. However, having said that, they both work, but ideally, your ideal balloon characteristics should be an adjustable one, right? It should have a low ulcer and obstructive potential. So it should be big enough that your pylorus, it doesn't go through the pylorus and cause a bowel obstruction. However, it should not have any sharp edges or any weirdness that is going to cause an ulcer or is going to cause a pressure ulcer or anything inside the stomach. Okay, the material needs to be able to last. It needs to be able to go through all of that gastric juice, goes through all the fluid boluses and the food boluses and still be able to last. Most of our balloons are FDA approved for 12 months, but that you'll see on the Obera and the SPETS, they'll offer a 6-month balloon or a 12-month balloon. Either way, it can last. The material is able to stay in there for 12 months. Right? And it's made to maximize weight loss and limit food intake. Now, the idea behind the balloon is that you add in something into the stomach, which is filling up most of the stomach. So your gastric emptying will be delayed because of this balloon in the way. It will increase satiety because now they'll be able to eat less. They'll be feeling fuller quicker. So it's sort of like a restrictive diet. Okay. When do we consider intragastric balloons? Now, intragastric balloons are quite nice because it does not change the anatomy of the stomach. It's not like a surgical intervention where once you've cut, you've cut. So it is a good option in patients. We're going to use them in patients with increased BMI, okay? They can also be used for patients with BMI of more than 50 who are unfit for theater. Because whenever we're looking at a surgical procedure, you've always got to look at, is the anatomy correct? Is the patient going to be able to actually tolerate what we're doing for them? Okay. And it can be used as a bridging therapy. So we can put the patient on an intragastric balloon, an endoscopic procedure, wait until they're at a lower BMI so that they can go for surgery. Okay. So it can be used for either primary weight loss, as a bridging therapy for bariatric surgery, or as a weight loss solution for our very high risk patients. So everyone needs to be individualized, and we need to discuss it with the patient to say, listen, are we going to be able to do this alone? Or yes, we can try this, but chances are we're going to need to do some sort of surgical procedure. A lot of patients do not want to go under the knife. They do not want to change their anatomy forever, which is understandable, but always a risk-benefit ratio. You know, if and I'll see what pictures I have for some of the patients that we've got currently. Right now, some of the contraindications that we've always got to look at when we talk about intragastric balloons is, has the patient had any prior surgeries? If there is any prior surgery, especially to the stomach, you cannot go and put in a balloon. And it's sort of self-explanatory. You've already changed the anatomy of the balloon, of the stomach, and you don't want to be going in there and blowing up something. Then there's a very high risk of your suture lines that are going to become undone, of gastric ulcers. So really any prior gastric surgeries, absolute contraindication to putting in an intragastric balloon. Coagulopathies. So you don't want to be doing these things on anyone who's going to be bleeding. Okay, so any coagulopathies, severe liver disease, if they've got any upper GI bleed, pregnancy makes sense because the baby is going to start pushing up the stomach. You're going to have a balloon there. It's going to cause a lot of discomfort for the mom. Okay, if patient has got any addiction, whether it is to alcohol, whether it's to drugs, we're not going to put in the balloon. And I put this in brackets because it's under the Obera contraindications to the balloon, a hiatal hernia more than 5 centimeters. And the idea behind that is that you're already going to have some sort of reflux when we put the balloon in. So if you've got a large hiatal hernia, you're already prone to reflux. You now put the balloon in, that reflux is going to be almost unbearable. Okay, so that's something to also consider. Okay, so this is how the balloon is. In reality, it doesn't really sit up there. It's going to be sitting down here because the stomach is going to try and push it down, thinking that it's a food bolus. Okay, so these are some of the intragastric balloons that we've inserted in the in-room theaters. So you can see we've got our anesthetist there, you've got the sister who's working with us, that's myself, and then that's the rep. Patient is in the left lateral position. We first do a gastroscopy to make sure everything is fine, there's no contraindications. Very importantly, patient is always monitored with a full crash cart available in theater. Now, when the patient gets the balloon, it comes with everything that we need, all right? That's the methylene blue that we put in, okay? It comes with the syringe, it comes with a cap. I'll show you the cap. This is the adjustable balloon. So if you look there, that's how it will end up. So that's the balloon, and then that little thing also goes in the patient, and that's the adjustable part. So this is the SPETS 3, very nice little thing. That there is to actually fill up the balloon, okay, and that's the cap. So this is done in rooms under monitored situation with the qualified anesthetist and everyone who knows what they're doing, okay? So I hope you can see this on the scope. The balloon is inserted on the scope. Through the scope, it then goes down under endoscopic vision. We then connect the little blue thing, which is there. We connect it and then we fill the balloon up under vision. So this patient here had about 650 mils, which was placed in the balloon. So the balloon must be expanded under vision to make sure you're in the correct place. This little thing is the cap going down. This cannot be left in the esophagus, so it must be pushed down so that it's in the stomach. Okay, once it's safely there, the patient is done, goes into recovery and done. Then they have to listen to the dietitian. They've got to follow a strict diet. There's a full protocol before insertion as well as after insertion, and the patient needs to follow up. Okay, this endoscopic sleeve gastrectomy. This is a new thing on the block. Not a lot of surgeons are doing it, but a lot of them are being trained in endoscopic sleeve gastrectomy. So what we do is same thing, but this cannot be done in rooms. This needs to go into theater. Again, the first like a G-scope is done first, make sure there's no contraindications to what we're about to do. Then this comes from First Medical, it comes from the company, it attaches to a scope. And then what it is that you go in and you take two ends of the stomach, okay? And then it sort of pinches it together, and then you control it from this little instrument outside, and then it fires a suture. So it's you just have to guide it, and then it sort of sutures through the scope. This is not one of my patients, but this one here, what they are showing is this is intra-op. So in the procedure, this is how it's going to look. What they've done is that they've just inebriated the stomach. So it's similar, but not the same to a laparoscopic sleeve gastrectomy. Laparoscopic sleeve gastrectomy, we'll go in, we'll take a staple. This is very now, what is like in, yeah. So we're not taking you procedure through procedure, but what we do is we take a stapler and then we fire the stapler and then make the stomach much smaller. This one, through the endoscope, it's inebriated. So at any time you can go and you can cut out those stitches. So this is in the actual procedure. This is a successful operation, how it's supposed to look on follow-up. This is a partially sort of successful procedure, and this one here is completely open. So the learning curve is high. And it hasn't been there so long as to say which one is better. Is it endoscopic or is it laparoscopic sleeve gastrectomy that is better? But the studies have shown that they are similar. So depends on the patient. You know, endoscopic is nice, there's no scars, but I like laparoscopic. Okay, then your surgical options, the way we look at the surgical options is we're going to divide it into 3 broad categories when we're looking at bariatric surgery. The first one is restrictive, where it's similar to the balloon, where you reduce the size of the stomach. And your laparoscopic lap band, so your laparoscopic adjustable gastric band, is a true restrictive surgical procedure. Your sleeve gastrectomy is not considered a restrictive procedure because you are removing certain hormones and metabolic factors, and that will then become a combination of both. All right. So you're going to divide it into 3 broad categories. You're going to have your restrictive, then you're going to have your malabsorptive. Malabsorptive is where we're going to bypass large portions of the small intestine. So the patient is going to be malabsorbing certain nutrients. And because of that, they are then going to have weight loss. Okay. And then you can have a combination of both your restrictive and your malabsorptive. So when you're looking at bariatric surgery, those 3 broad classes. Okay. Now, I wanted to put this in so that you know, depending on the type of procedure that was done, what is the most likely deficiency. And most of the time, patients don't come back to the surgeon when they've got these deficiencies. They think it's normal. They're going to go to their GP or to someone close to them. So if you look at the stomach, right? So the stomach is going to be having your intrinsic factor for vitamin B12 absorption, protein digestion by pepsin. So if we do any sort of gastric procedure on them, they're normally going to come in with the vitamin B12 deficiency. And most of the time, we give them supplements to say, okay, you're going to take vitamin B12, you're going to take calcium, you're going to take vitamin D and whatever. But if the patients don't really know, they might have a deficiency in that. So the stomach is really your vitamin B12 intrinsic factor. As you're coming down into the small intestine, it's your iron, calcium, magnesium, your zinc, right? Going down further into the small intestines, it's your fat-soluble vitamins, vitamin A, D, E, K, your lipids, your cholesterol. Going further down, vitamin B12. So this is a nice thing to have, just to say where is things normally absorbed, and if we had to cut that or if we had to bypass that, what are patients going to come in with. Okay, so as we said, now I didn't go through all. So if we look at your malabsorptive procedure, your BPD, your biliary pancreatic diversion, not done that often, and your duodenal switch. Okay, so your side effects, your diarrhea, vitamin A and D deficiency, and a protein malnutrition. So these patients will need to have increased protein requirements because they're not going to have that much to be reabsorbed. The right complications, these are more surgical complications. It's your surgical site infection, whether it is superficial surgical site infections or if it goes more deeper, surgical site infections. And then because there's so many bypasses and so many anastomoses, your anastomotic leak is also quite high. And then your Roux-en-Y, which is sort of your gold standard when it comes to a bariatric procedure. Your deficiencies there to watch out for is the calcium, selenium, zinc, iron, and vitamin D, right? And the complications being marginal ulcers and anastomotic strictures. All right, now I got a picture here. So this first one is a duodenal switch. So you can see the gastric sleeve. So the stomach is made smaller. This is then bypass going all the way down. Bypassing more of your small bowel and giving them less amount to actually absorb those nutrients. This one here is the Roux-en-Y gastric pouch. So you can see the stomach is made smaller, much smaller, 15 to 50 mils. your alimentary limb comes there, and then your biliopancreatic limb. So here you're not moving anything. You're just cutting your stomach, having one limb, the rest of the stomach then goes there. And then again, the common channel is related to how much weight loss you can expect. Shorter the common channel, the more weight loss you have. So this is one of the patients that we had that wanted a balloon. Didn't really tell us what she had previously. And this was what we saw when we went in for a G-scope. So here you can see, this was the sleeve gastrectomy that was did. You can see the suture lines there, and then here you can see a bypass. So her stomach was less than a centimeter. You came in and you went almost straight into the two limbs of the bypass. So this patient was definitely not for a balloon. Now, just with anything that we do, the goals of medical or surgical weight loss, it's not a magic bullet. And I think patients need to realize that, because when they come to us for any medical or surgical intervention, they've tried using diet, exercise, it did not work, and now they are at that point. So it's very important to stress to them that it's not a magic bullet, and this has to maintaining healthy behaviors will minimize your risk of weight gain. And that's where I stop. So maybe we can have a little discussion from everyone on the online. Dr. Bila?
Thank you very much, Dr. Jaffer. I think it's a good way of ending there to indicate that the medical and surgical weight loss is not necessarily a panacea for weight loss, but you're saying that it is a tool, but also that we need to manage ourselves in terms of weight loss goals. Thank you very much. It's been a great presentation and quite a high tenor that we've had this evening. Colleagues, please, if you have any questions, please don't hesitate to post your questions on the chat box, or alternatively, just raise your hand and I'll unmute you, then you can ask your question. There was a question that was posted here. I'm trying to look for it now. I hope I didn't lose it. Yeah, but I would say it's a great presentation, which is cost effective between the balloon and endoscopic gastrectomy. How much are we looking at, and does the medical aid cover this? I'm glad that from our hospital we have one of our founder managers, Ms. Joanna Nosima, was here. If you want to chip in there, you can also talk there, Joanna. Okay, go ahead, stopped.
Okay, so let me put my 2 cents in. So the intragastric balloon is quite nice because we can do it in rooms. So when we're looking at in-room theater, we really do save a lot in terms of taking the patient to theater. So we save on that. In terms of how much are you looking at, the balloon goes for about 20,000, the balloon itself from the company. And then you're looking in total at about 60,000 for the procedure. So most of the time, medical aid depends which medical aid it is, and some will cover a portion of it. So the patient will have a co-payment depending on their medical aid. Sometimes it is completely covered with the higher classes of the medical aid. It will be completely covered by them for the intragastric balloon. Some patients might have a co-payment of 20,000 depending on their medical aid. The balloon companies normally do fund the patient for the entire thing, with the balloon, with the insertion, with the extraction, with the SPETS3. I know they do also cover for anything that we need to go, if we need to inflate the balloon a bit more or deflate the balloon. So ballpark figure, 60,000 medical aid does cover. In terms of the endoscopic sleeve gastrectomy, that has to be done in theater. It cannot be done in rooms. It also needs a special equipment that you attach to the scope. So that one there is much higher, and much higher being about 80, 90,000. Again, medical aid will cover a portion of it. I haven't seen the medical aid cover the entire ESG as yet, but it is still very new in South Africa. And I think as we go along and medical aid realizes that we can actually in the long run save on complication costs of the diabetes or of the hypertension, medical aid will be more prone to supporting funding the endoscopic and some weight loss procedures. So we'll see where that leaves us.
Okay, yeah, with NHI coming, we'll see what's going to happen.
We'll
now,
see.
the next question is about public and sector practices. Which is the commonest of the surgical options in the public sector and why?
Yeah, so that's a good question. So public sector has gone through little phases, and it started off when bariatric surgery had just started. We did a lot of sleeve gastrectomies, and there are still people who do a lot of sleeve gastrectomies, and their bariatric practices focuses more on that. But now what we're doing is our laparoscopic Roux-en-Y bypasses, and the reason for that is that it is the gold standard in bariatric procedures. It's a combination of both restrictive, because you are taking part of the stomach out, and you are bypassing. So in the public sector, laparoscopic Roux-en-Y. In the private sector, very specific surgical candidates will go for it. And with those procedures, the places do need to have a proper bed that can accommodate the larger patients and things like that. So laparoscopic Roux-en-Y. I hope I've answered your question there.
Okay. There's a question which is not in the chat box.
Dr. Ngatani's hand is up.
The question they want to find out about whether when you do that presentation, prevention as well, and clarify childhood obesity to diabetes, type 2 diabetes in young people, in the youth.
Sorry,
it will lead us to the next question about diet control.
Okay, I didn't get the whole question.
Can you hear me?
Yeah, Ken?
Yeah, I think if you could emphasize on prevention as well, and clarify childhood obesity to type 2 diabetes in young people. I think, yeah, I mean, when you ended, you spoke about that, there should be other modalities of preventing the obesity, but prevention and also type 2 diabetes in young people in relation to obesity.
Okay, so I hope I answer your question. So prevention is always better than cure, and the problem with some people is that it is either cultural or it's just ingrained in the family, and I'll speak from experience as an Indian. People eat a lot, and whether they're young, they're old, they're going to eat. And it takes a lot for people to stop eating. And we see a lot of young children who are already big, who are already diabetic, and not type 1 diabetics. They are type 2 diabetics. So how can we get that? Is it more primary health screening tools? Is it more going to schools? Is it more introducing more health aspects into their life orientation subjects? I don't know. And I think we can have a discussion on that. But the problem that we are seeing is younger and younger patients coming. And if they're starting off with diabetes at a younger age, they're going to be having complications more quicker. And another thing from a surgical point of view is that we don't want to necessarily start doing interventions to children less than 18. There we would really, really go for diet, exercise, things like that. But I've seen a few patients that's come who are 16, 17 that want some sort of intervention. I try and postpone it as best as we can, but if they are up to it and they are mature enough to understand what we do in the risks and what they have to do from their part, we can go about and do it. But in terms of preventing childhood obesity, I think it's something that is bigger than me, and it has to come from somewhere much higher.
Okay, thanks a lot. I see Dr. Malefetsa-Ngatane's hand is up. Doc, can you unmute yourself and ask your question, or come on, unmute him? Dr.
Hello,
Ngatane?
can you hear me?
Yeah,
Can you hear me now?
I can hear you.
Thank you. Okay, thank you for a good presentation. The issue that I want to find out is with especially the surgical procedures. If you have a patient that is non-compliant, because sometimes when we take them to dietitians and things, they say to keep to the demands of a dietitian, the food is expensive and they cannot afford. Now, which means they'll fall on the wayside. Now, what is the rate of people asking for the surgical procedures to be reversible, and how easy is it for reversibility of those procedures?
So good question. So a lot of patients come in not because, so they normally come in because they've got deficiencies to certain things due to the malabsorptive procedures. And that can normally be fixed with just supplementation, going above the normal limits of supplementation. But it's very difficult to actually reverse these things. It's possible. It's not a nice operation, and it's not something that a lot of surgeons will willingly put themselves through to say, okay, we're going to go now and reverse it. Remember, now you are looking at adhesions. You've got to do full adhesiolysis. You've now got multiple anastomosis, which you've now got to reverse and then try and put back together. So in terms of reversing it, very, very difficult. And I think that's why before anyone has got any surgical procedures done on them, there's a rigorous process where they go through psychologists, they go through physicians, they go through dietitians, they come to the surgeons, and everyone is giving them counseling on almost the same thing to say that your entire life is going to change. And there's certain complications that they've got to be aware of. Food is going to change, supplementation will be there, looking at the cost of supplementation. So if the patient did not want to follow a dietitian because of certain costs related to the diet, it would be very irresponsible for the surgeon to say, okay, I'm going to now do a full surgical procedure on you, knowing that the costs are also going to be there with the supplements, with certain foods to eat. So really reversing these things, we've seen it, people come in. Luckily, most of my patients have been managed with just increasing their supplementation, but very difficult to reverse. So before you even go ahead and say, I'm going to start cutting, the patient has to be in the right mindset. They have to know how it's going to affect them, because a lot of patients, when they come to you, they are very desperate and they will say yes to almost anything. And I think that's why you'll see a lot of surgeons will take their time before the first consultation and actually doing a procedure, just to see if the patient is actually willing to do what it takes to have these procedures done. Because it's very easy for me to go and I tell my patients, I can go and do it. We can cut it, we can do everything. But will you be able to continue doing what you need to do to actually make this work? Because remember, it's a give and take. I can meet you there, you need to come and meet me there. I can cut out whatever you want, but if you are going to still continue eating the way you do, not doing exercise, not listening to the dietitian, there's not much that we can do. And these patients, unfortunately, are the patients that will come in your office almost every week with some sort of complaint. So before you even do it, really make sure the patient is in a good mind space, not desperate, not just saying yes, yes, yes to everything you say, really understanding what it's going to take, and then following the process and listening to what they have to do. Did I answer your question, Doc?
Yeah, maybe we can make a follow-up with a question
Yes.
that was posted before Dr. Ngatane asked that question, because the Kodi Togon is a dietitian herself.
So I see this, how many behave by Dr. Kodi, how many behavioral modification sessions?
Yeah, giving up before dietitian counseling, pre-op and post-op. And I think she wants to know how many do you have?
Yeah, so in my practice, we have five pre-op with the psychologist, with the dietitian. So as in 5 with the psychologist, 5 with the dietitian pre-op, and that's a lot, I know. But as I said, I want to make sure the patient has actually, they understand what they have to go and do. It's very easy to do a procedure, but yes, we want to, and we have MDTs, so we have multidisciplinary team meetings where everyone comes about and says, okay, I think this person is in the good frame of mind and they understand what it takes. Yes, we can go ahead. And everyone comes together and we sit before we do any operation on them, including the balloon. So for the balloon, I don't have 5 sessions before. There we go 2 sessions, but definitely getting the psychologist involved, getting the dietitian involved. Post-op until they are adherent to the diet, until they don't have any deficiencies, until they are comfortable with what we've done. So even if it has to go longer, it goes longer.
And then now that you've spoken about balloons, any experience with a Lorian balloon? I don't know what it is, but I'm sure.
So yeah, so this balloon is the one that you can swallow. It's great in theory. I love it. The patient swallows the balloon, you give them some water, take an X-ray, make sure it's in the right place, and then it is inflated. And then the little connection between the outside and the inside is then detached, and the patient has got a balloon without the scope. A lot of our patients that I've seen this, they cannot, because if I can go back to the presentation, 2 seconds. Okay, this thing isn't working with me. But if you go back to the presentation, that entire balloon, it comes into something that is about 4 centimeters that they have to swallow. Now you can't really put KY jelly because it's just, no one wants to be swallowing that. It's quite an unpleasant experience for someone to swallow it. We've tried using some sort of like oil. That's also very, very not nice to swallow. So your patient really really needs to not have a gag reflex, firstly, to get it down. And then you need to be 100% confident that you are not in the esophagus before you go and blow up your balloon. So I'm not a fan of it, because we did see one patient that someone had the balloon inserted via the X-rays, and it had caused quite a large mammary waist tear, and that was because it was halfway in the esophagus when they started inflating it. So it popped down eventually, luckily didn't cause a perf. But for me, I'm not willing to take that risk. So I'd rather like to see the balloon, make sure it's in the stomach before we go and we inflate it. But it is a good concept, and I think with time, with time, they'll make it better, they'll make it smaller. So yeah, it's something to watch out for.
I was about to ask you from an uninformed position, who comes up with such weird interventions? Don't have to answer it. The question is, interesting information. Are there any precautions on the level of physical activities post-management with any of the procedures?
Good question. So with all of them, including, so your least invasive is your endoscopic. The least invasive is your endoscopic balloon, so your intragastric balloon. With that as well, remember post-op, they're going to be vomiting a lot. They're going to be having cramps. Their body needs this time to adjust. So it depends on the person. It depends on how they actually react to the intervention. But generally, we say for the next 14 days post-op, you're not going to do any heavy cardio or any heavy weightlifting exercises. So what we do is the same as how we introduce them on feeds and fluids. So you're first going to start off with fluids. When their stomach accepts the fluids, then you're going to sort of move on to mixed fluids. We do the same with exercise. So what I normally tell my patients is, in the first week, we're just going to walk around the block for 30 minutes. Nothing special. You're not going to be killing yourself. You're not going to be going for spinning exercises. You're not going to be hitting the gym because I know you're on a diet, and that's what diet means, right? Diet means eating less and going to the gym. But we've got to give our bodies that time to adjust to what we've just done with your GIT, because if we are vomiting, everything that we put in, we're going to be dehydrated, you're going to go to the gym, you're going to collapse, and then there's going to be issues. We're putting ourselves 10 steps back instead of just giving your body time to adjust to the balloon, to the endoscopic sleeve. Laparoscopic, you need to increase that time a bit, from 2 weeks maybe to about 3 weeks to a month before we start hitting the gym. If we're doing it open, that's also going to be pushing it back. So we want patients to get on a diet or get on a exercise regimen as soon as possible, but keeping in mind that you're not the same person you were yesterday. You know, you've had a procedure, no matter what it is, and you've got to give your body that time. If you give your body that time, you can then push more in the future. Okay. So
yeah, thank you very much. We're going back to children.
Yeah.
Are there any options for children? I know that, you know, pediatric surgeons, I'm not sure if it is their field also.
Yeah, you know, I
Maybe
don't
you
have
see
much.
children.
Yeah, so the most of my patients, the youngest I've seen is 12.
Whoa.
And for that patient, really, we just did diet, exercise, and I think when the child was about 14, I put in the balloon. But in terms of surgical options, I'm not a pediatric surgeon, but I don't think that our pediatric surgeon would also be too keen to put a child under a surgical weight loss option that early on, but I stand to be corrected.
Okay, yeah. I'm not sure if there are any surgical pediatric surgeons locked in tonight. But if they are there, they can comment. But Dr. Hotel wants to know, ideally, how long should the patient be on medical intervention like Saxenda?
So the problem with Saxenda and Ozempic is that it needs to be sort of a chronic medication, because the moment you stop it, you know, most patients, they say about like 80% of patients are going to regain the weight that they lost. And that is because you have not changed the idea and the outlook and the attitude towards food, exercise, and weight loss. You've altered the hormone interaction, you know, you've altered things in the brain to make them feel full. You've altered things. So ideally, the patient should be on it for at least a year or more. And in that year, you are teaching them how to look at food, how to gauge for themselves how much to eat. And that's where, so when my patients go on the balloon, we're teaching them how to look at food and how to have a healthy relationship with the food. However, there are times when the patient is going to plateau. And if they do not have the SPATS3 where we can go and adjust and add more fluid to the balloon, we then put them on things like Saxenda and Ozempic. And that's just to kickstart the weight loss again. But you know, to answer your question, ideally how long? At least 12 months to 18 months. Anything shorter, I think we're not really going to be achieving what we wanted to achieve.
It's a long-term plan.
Definitely.
And the balloons, what's the lifespan of the balloon?
So it's FDA approved for 12 months. So all balloons, whether it's from Obera or from SPATS3, can last for 12 months. I tell my patients we don't have to keep it there for 12 months. If we reach our goals and we maintain our goals for at least a month, even if we remove in the balloon at 8 months, it's okay, it's fine. But it's not, there's this idea out there that there's a 6-month balloon and a 12-month balloon. It's the same balloon. There's nothing different between the 12-month balloon or the 6-month balloon. So to answer your question, FDA approved for 12 months. After 12 months, we go in, we remove the balloon.
Thank you.
Okay.
And back to the question of medical aids, I'm not sure the question or comment, that the medical aids, are they keen to fund for vessels in general?
Definitely not. Well, you can, saying that it depends. So if the patient comes in with an obstruction, or if the patient comes in with a marginal ulcer that's perforated, it's now no longer a weight loss procedure. Now we've moved to an emergency surgical procedure. So in that case, yes, the medical aid will fund it. The medical aid will fund it. Medical aid will fund the ICU, post-op, high care, whatever, they will fund it because it is now an emergency operation. However, patients come in elective procedure for reversals, they're very, very finicky about it. Then we've got to write motivations, and most of the time it's not approved. But that's a big difference between elective and emergency.
Yeah, okay. Yeah, it's been quite an engaging session this evening.
Love it.
Yeah, well, how bad is the reflux IGB
Insertion.
Yeah,
So,
how bad is the reflux to be insertion?
So there's a whole protocol to how we do the balloons. It's so for a couple of days before, we're going to already start them on a PPI and then post-op as well. Remember, you've got this big balloon there. Your body is not used to it. You've got the balloon. Most of your fluids and everything that you've got is not going to have the same gastric emptying as we would like. So the reflux is not bad. It is there and it can be controlled with PPIs, but the patient must be on a PPI. But it's not, I haven't still needed to remove a balloon because the reflux was so bad. Yeah.
Yeah, thanks a lot. It's been quite an engaging session, as I said earlier on, with so many comments and questions and quite a number of affirmations, a good presentation, very informative to the point. This is bariatric surgery generally, it's part of this program, maybe for clarity's purpose, or for myself maybe. And also if that's what you're establishing generally in your practice.
Sorry, Dr. Bella, I didn't, you're cutting there.
Oh, sorry, no, I just saying that in terms of basically doing weight loss programs in your practice, just for clarity, is that going to be part of bariatric surgery, or this is the whole of it? It is subset of bariatric surgery, or bariatric surgery can be a bigger discipline on its own?
Yeah, so in my practice, I'm focusing on the weight loss management, whether it's diet, exercise, the lipolytic injections, balloons, and then bariatric surgery. But it is it's a vast, it's a vast field. And I think whoever is out there that wants to do certain areas of it, there's a lot of surgeons that only focus on sleeve gastrectomies. There's certain surgeons that only focus on laparoscopic Roux-en-Y. So it's vast. In my practice with my patients, we try and give them a holistic view. So it's not like you come in, you get the balloon, you get the endoscopic sleeve, and bye, I'm never going to see you again. So, but it's a young field, and I think with proper programs in place, we can do the right thing for the right patient. So yeah, I hope it helps patients out there, and I hope this presentation helped also the doctors on here to see the patients that are coming in and what we have to do for them, because not everyone is going to follow up in my surgery.
Now that we have you on the platform and you've got an audience, how would people, I see your details on the screen, but maybe just talk a little bit about how to get hold of you and what type of patient they should be sending to you.
Yeah. So I must come with the light behind me or something. So so what we're doing is we really are trying to provide a holistic management to these patients, from coming in, seeing what is wrong with them. And many patients are undiagnosed diabetics or something. So the physician is key as well to our practice. Patient comes in, has a consult, we then start them on a diet, on an exercise, start them on some individualized lipolytic agents via IV or whatever it is. And then we go and do the balloons, and then if need be, we can go and do the surgical procedures. So as Dr. Billa said, We're at Clinic September and then at Lenmed Randfontein. So the patients that we would ideally want is patients that are serious about losing weight, that want a plan and do not mind following through with the plan. I think that's very important. So it doesn't really need to be a very huge patients with a BMI of more than 40 or more than 50 that's already got complications. They can come to us as well. We can help them. But it starts all the way from your BMI of 30 or even less. So anyone who wants to lose weight, send them through for a consultation, and then we'll tell them, yes, this is for you, or no, this is not for you, or we are only going to do the weight loss plan and no medical or surgical interventions. So yeah, Dr. Billa, to answer the question, it's anyone who really wants to lose weight, we can help them with it, with a holistic, healthy way to do it. It's not going to be an overnight solution, and you're not going to see me once and I'm going to say, okay, I'm done with you. We're going to see you throughout, and we're going to make sure that everyone, including your local GP or whatever, is on the same plan as what we want.
Okay. Thank you very much. Quite an enlightening session that we've had this evening, and thanks for taking your time to prepare this presentation and share your knowledge and experience and impart information to everyone who's been logged in this evening. And I trust that colleagues will be in touch with you. This information is available on YouTube for anyone who wants to go back and watch the presentation. They can do so on our clinic's YouTube line. Just go to the YouTube page and just like us in Phoenix, and you'll get all the past presentations and also be informed of future presentations. And so on behalf of Clinics Health Group, Dr. Tanwir Jaffer, we want to thank you very much for this time that we've had with you, and quite a high attendance also, must say. And
thank you so much. I hope that everyone has learned something, and we can all share knowledge.
Definitely, I think we've all gained something. And also to thank your colleagues. I think without you, we can't have this webinars, and thank you for continuing to log in every week, and we appreciate your presence every week and your support, and we trust that you will also join us next week. We've got an exciting speaker once for next week, but we'll send you invitations that effect. And also to thank Clinics Health Group marketing team that I work with, Gamu and Zistoko, for always making sure that we've got logistics planned and prepared for these meetings. And we shall also meet you again next week, and have a good evening. Thank you very much.
Cheers. Thank you.